Good afternoon, everybody. We'll give it another minute or two before we get started.
Well, good afternoon, everyone. I keep getting messages. I thought you were out today. No, I'm out starting this evening, but wouldn't miss the town hall. I'm really happy that today we're going to highlight the work at the School of Public Health and Information Science, and I don't want to take any of their time, so I'm going to throw it over to my friend Ted Smith and let Ted kick things off. Ted?
Great. Thank you so much. Really appreciate the opportunity to highlight some of the interesting work I think that's going on at the School of Public Health. So just as a way of context, so I'm Ted Smith. I'm currently serving as Interim Associate Dean for Research over at the School of Public Health. And I want to share with you just for a few minutes today some of the work we've been doing on the research administration side. And then I'll be joined by two of our faculty who will share some of their interests, for the benefit of the community and hopefully to spur future collaborations across the institution. So I'm going to go ahead and share a little bit of what I'm talking about. And you all tell me if you can't see it, I'm sure. Is it full screen? Anybody?
It is not.
It is not. No button. Isn't our friend? There we go. Okay. Let me give you some caveats. All of the imagery was generated by AI, so it's mine's or not that exciting. So we're going to really focus on the content. I want to the office for various tools that this whole project is built on. So I wouldn't be able to talk about any of this if the institution hadn't made a commitment to, things like Pivot and Dimensions and ORCID. So what I want to describe today is a system that we've been building to help our faculty work with those tools better. It's very much a pilot. We've been at it for, 3 or 4 months. And we're just trying to figure out whether there's any way we can use these tools in some way to move an investigator from, kind of what their credentials look like on paper to who they might be able to collaborate with, and then ultimately, of course, sources of funding and resources to help them pursue their agenda. So I don't know that it's a Gordian knot the way it is. Again, AI made the graphic, not me. But yeah, I think it'd be fair to say, these tools left on their own capable of working in that environment. But I think our job in research administration is to to continue to try to push to be as helpful as possible. So build on top of all of these tools is a whole sort of extra layer of analytics that we've been pursuing. The basic organizing principle for this work is to sort of take the perspective of a grant reviewer or study section member who is going to be looking really at what was submitted, right? And I think we all know this, that, our credentials are something that, we as scholars are usually pretty transparent about and accountable to. It's not a fiction that we get to rewrite. It's the record of our accomplishments, right? So we use that as the foundation for this system. So what does your CV actually say, you've done? What are the things that you know about? Who have you worked with? And that foundation the future, right? And so the process starts with, what do you look like objectively on paper to somebody who hasn't met you, doesn't know your work necessarily, and then how do we take that information and then work our way towards possible collaborators for you in those fields of your demonstrated expertise, and then how might we identify more directly funding opportunities that match your expertise. And then, of course, the last step in the process is, what did we get wrong? And so in the first couple of months, we probably have a lot more that we've been sort of auto-correcting for than successfully delivering, but that's all sort of part of it. So the process, has these sort of 5 stages. So ingesting, your CV, your biosketch, your profile, which, as we all know, sort of migrated to ORCID profiles. So these are the sort of the definitive documents that we say who you are and what you know. Those documents get parsed and then mapped into topical categories. And we rely heavily on these LLM frameworks for doing this sort of parsing and feature extraction to come up with a kind of a standard language that then we can work across to a variety of platforms from. When you look at the investigator's background and their accomplishments, there are many dimensions to that scholarship. Often, there can be methods, there can be geographies, there can be other contextual factors, clinical trials or observational data or whatever it might be. So the parsing activity is really trying to establish a robust understanding of this scholarship, if you will. Okay, that goes into ChatGPT for some extra extraction and massaging, and that helps us get to a standard topical nomenclature. In the trade, it is the ANZ SRC, the Australian and New Zealand Standard Research Classification Framework. That's the lingua franca of the research taxonomy in a lot of these tool systems. So really going from natural language recognition into these standards is an important part of the process. And then that gives us the option to interface with Dimensions. And for those of you that haven't used Dimensions, it's a fantastic tool to help you visualize and find, folks who are in specific fields. And so if I can go from your CV to then who in the world, are accomplished, published people in these areas, that is a step towards finding collaborators. I think when we rolled out Dimensions here at UofL, there was an early and important focus on who else at the university is doing the kind of work that you're doing. I think we're just sort of making sure we're expanding the aperture and saying who's really productive in these topical fields. And you might consider, you probably know in many of our cases, who the accomplished people are in our fields. But in some situations, we've seen names will come up that just thanks to the magic of indexing, you might find somebody that you might not have met at a conference or read their work recently. So that's really the goal there. So for us, we call that a topic card. What are your topics that we then meet other people who are good at those topics or accomplished in those topics. Here's just an example in the School of Public Health. One particular faculty member and their publications. We can see that there's a little bit of variation in the sort of subject matter of the publications, not a lot, and there's some common themes, and that's where the AI is helpful. So it starts to extract the sort of meta-organizational themes behind the publication record. And then, as I suggested, parses it into very specific categories and then codes, and then can get us to potential collaborators. So, and this is a real example of, somebody who has been doing some work in women's health, and this gives us an opportunity to take a look at who the most published people are in these particular topic fields. I don't think it's a surprise to any of us. Often the most published people are also the most highly funded people. And so, I view this as one leg of a stool to get toward funding in a team science environment. So, to the extent that there are names that are popping up as important in a field, potentially they are folks that are worth reaching out to for potential collaborations and then potential funding. So really important that we have that dimensions database to work with. And here you can see another sort of example of what the system kicks back, for our investigators to consider. So everybody's sorted and ranked for their publications and citations, and obviously people can drill down on the details of those individuals. Okay, so that gets us to collaborators. Once you have that information about topics, then we have a parallel track that goes just directly to funding. So forget about the collaborators. This is what you know about who's funding it. Now, in the school department, have really faced some serious headwinds with this current administration. Topics that were really established and very routine in public health are no longer necessarily in vogue, and so there has been a shift in some of these areas towards non-federal funding, and so that's where the Pivot database has been remarkably important, because that's obviously surfacing, professional association, private foundations, public foundations, which really are a lifeline for some of our investigators in public health. And so again, we take the topic cards and those codes, and then we run them out to Pivot, and then we come back with some funding opportunities that we then bring back to the investigator, put up on a SharePoint site, come back to the investigator and say, take a look at these. Are any of these funding opportunities, in your view, a fit for your work? And then, we either learn that, the topics weren't as ideal as we learned. Cases where geography has been a challenge with private foundation funding, where, maybe it's only available in the Pacific Northwest for studies in the Pacific Northwest or something like that, where it wasn't as clearly discernible out of the AI. But for the most part, most of the time, it's producing good results that then, when we feel good about the way that system is working, every month, there's an update query against Pivot for the topics. And for many investigators, especially the further along in your career, there are many topics. And so that's great, because that's more funding opportunities that are potentially available. So that's really then a service to the investigators, right? Because we're saving them a step of, I forgot to go look to see if there's any new funding available. So we're just rarely in our maybe second month of monthly updates to the investigators about funding they might want to consider. And then in our own grants support at the school, that's where we keep track of I'm interested in pursuing this particular RFA. And then that really moves to our pre-award kind of support for those staff. And we remind/nag to make sure that folks are on track for those solicitations that they identified that they're interested in. And so here you can see just some examples of things that we're kicking back to these investigators. And remember, this is coming from a big database of thousands of things, and it's saving them all this sort of keyword time and poking around. Here's a few testimonials of happy customers out of the faculty. I truly appreciate the cooperation and the patience that some of these faculty have brought to bear, because we are just all experimenting at once here, and it's a social contract that we're trying to honor in a good way. But early in, I'd love to come back and tell you how we've done, hopefully achieving some of these collaborations. But I wanted to show you all today a little bit of how we're sort of playing with these tools, wide open to any kind of collaborations across the institution, if there's interest in others poking around in this particular way. And then I'm going to just suggest that we've always got things to work on. So we're going to continue to think about how APIs, especially to pivot, could be helpful to make this go a little less manually. But and of course, we're interested in closing the loop of what's the close rate given the stuff in the top of the funnel. So we'll be working through all of that. I certainly didn't do all this by myself, of course. Hema and Chris on our team, they're both data analysts who are working part-time at the university, have really designed this process and executed this process. And so I'm truly grateful to their partnership. And with that, I will stop and happy to answer any questions. And if there are no questions, I think we could move on to our next speaker.
So next up, we have a presentation about the Rural Heart and Lung Study, Epidemiology and Community Engagement in Rural Kentucky by Stephanie Boone.
Stephanie, you're on mute.
Okay, thanks. I should know better. It's not really COVID anymore. So thank you, Dr. Klein and Dr. Smith, for having me today. And thank you, everyone, for joining during your lunch hour. Today, I'm going to briefly go over a lot of stuff about the Rural Heart and Lung Study, but hopefully give you just a glimpse into what are some possibilities, what are we doing now, where are we, and what are some possibilities for collaboration, as well as my research interest. So I hope you all don't mind. I'm going to get off camera because I'm actually not feeling that well. Let me go ahead and share my slides. Okay, can you all see them?
Yep, they're on full screen now.
Yes.
Okay, thank you. The Rural Heart and Lung Study, rural is, we love long acronyms, the Risk Underlying Rural Areas Longitudinal Study. This pie in the sky idea for this multi-state study really started in 2017 when the main PI, Dr. Vasan Ramachandran, he's at the inaugural dean at the UT School, San Antonio School of Public Health, got a big group of us together to talk about rural health and starting a brand new epidemiology cohort study, filling a gap in the NIH portfolio that was really needed in terms of statistically powering a study to be able to evaluate health outcomes in Mississippi Delta and Appalachian populations of the southeastern United States. And so we began in 2017 to work as a group, and I did focus groups in the counties that I'm going to be talking about, and we submitted our grant in 2018, and this journey started in 2019 as a funded UofL project with the NHLBI. And
Stephanie,
so
you're not in presenter view. You might want to just put it in presenter view.
okay, thank you. Is that it?
Yes, that works. Thank you.
Did you all see the first slide?
Yes, we can see it.
Okay.
Thank you.
And so as a UofL grant, this is really focusing on infrastructure. And, we do have some ability to test some scientific hypotheses, but really we're building our baseline cohort study. And part of this large study was to focus on community engagement and thinking about why some of these heart, lung, and blood sleep disorders differ among certain rural communities that have similar socioeconomic profiles. And so just to give you a snapshot of our study team, we have 16 cores, and so I'm one of the core PIs, and my core, which also known as the Kentucky core, is responsible for the study infrastructure, but also community engagement here in Kentucky. And I'll talk a little bit about that. But really, we focused on these 4 states for a multitude of reasons. So looking at prevalence data across the United States, we see that prevalence of heart disease rates among adults ages 35 and over are not randomly distributed in the United States. Some of these darker red counties and areas in the southeastern United States have higher rates of developing heart disease. As you can see, the darkest red is in several of the counties here in Kentucky. So this age-adjusted prevalence being 416 to 810 per 100,000 within this quintile. And so then you take a closer look at death rates for cardiovascular disease and find that these states are also higher in death rates. And this variation is very widespread among Kentucky in and of itself. We have these eastern Appalachian and some western counties that have higher rates of cardiovascular disease death, which actually this also mirrors the cancer mortality rate distribution as well, which are the top 2 causes of death in Kentucky and in the United States. And so looking at just plainly overall rural and urban Kentucky, you can see here that the death rate is 247.1 versus 183.1 in rural Kentucky versus urban Kentucky. And then when we break it down by Appalachian designation, it's 45% higher than the national rate and 32% higher than the non-Appalachian Kentucky areas. And so why do we care about this? And the reason why we're really focusing on just rural areas is because rurality is a spectrum. And we know that there are various contributors to poorer health outcomes, but really trying to understand the variation within rural areas has become increasingly relevant as we try to better understand community capacity, as well as identifying unique factors that are contributing to the higher health, poorer health rates in these areas. And so we started to design a study where we were focusing on 10 rural counties, and this is focusing on men and women between the ages of 25 and 64. The focus of younger populations really stems from the evaluation of premature mortality and incidence of higher rates of working age, so early and middle-age adults in the population. This is true across the population, as I'm sure some of you all are seeing in your work, working with early stage diagnosis. And then from there we dwindled it down to these 10 counties / parishes. And so in Kentucky, our target is to recruit approximately 1,600 participants, which is about 35% of the overall target sample. And so just to briefly go into this, this is a unique design feature of this study is it's an ecological pair design. So we are pairing high risk and low risk counties. And so we looked at rates for CHD, CLRD, and stroke rates in terms of mortality, a summary of these rates, or an average, if you will, over the 6-year period prior to 2018, which actually some of these rates have gotten worse in the county pairs that are in Kentucky over the last 6 years. And so we picked these based on geographic representation across the 4 states and presence of a pair within 3 of the 4 states. We have 6 high risk and 4 low risk counties. And we also wanted to stay focused on rural, like I said. And so briefly, just so you know, there's a very interesting discussion about, recruitment and, trying to reduce selection bias in cohort studies. And, it is easy to go out and do, convenience sampling and things like that. But to be able to actually discuss true prevalence within a target population, we really need to think about probability-based sampling. And so the goal of this study, which has been modified since the beginning because our probability-based sampling was utilizing address-based sampling, where we were making decisions about oversampling within certain population strata to try to get more of these subpopulations to participate in the study. For instance, in Kentucky, we oversampled in areas of the counties where they were ages 25 to 34, high proportions of households between the ages of 25 and 34, and then doing a random selection and mailing invitations. And what do you know? People don't always respond to their mail and may not always get it. And then we also had issues in the two Appalachian populations in Perry and Breathitt County, which is in eastern Kentucky, where there were a lot of PO boxes and a lot of renters. And so we had to work through a lot of these challenges. And so we invite people from the household. We roster a household to determine eligibility, which eligibility is having lived in the county within the last 6 months and no plan to move in a 2-year period, as well as being within the age range and living in a home and not in transient housing. And so then from there, we actually rostered individuals, so more than one person from a household could participate. And so we just did our last mailing for Boyle and Garrett. I'll talk a little bit about where we are now because we're in Kentucky recruiting. So this is exciting that I'm presenting all of this to you all finally because we're about to wrap up our baseline cohort recruitment. So the second part of our recruitment would be the non-probability based sampling. And so right now we're hovering at around 50% of our study sample for the entire study is really coming from this non-probability based sampling method. And this is in large part the community informed engagement that I do in my core. So when we do distribute data sets, there will be sampling weights that are going to be created in these analyses to reduce the possibility of selection bias. And so like Ted said, it's similar in my situation. It takes a whole family of people to really make a difference and to move the needle. And so I'm pictured here at a community event, a community fair in Boyle County. And this is Dr. Steffi Abraham. She just finished her PhD in epidemiology last semester. And this is Scotland Stewart. She's an epidemiology PhD candidate. And they have been part of my research team for the past 3 years and have really helped move us forward. And so briefly, just to talk about our engagement, we really started, I guess, boots on the ground. Well, we started having meetings in 2019. We really, COVID happened and it kind of pushed everything back for about a year. And so in 2021, we really started to think about how we can grow our organic networks through in-person events and hosting health fairs, as well as really building our social networks. Once we started being a consistent presence and discussing health educational opportunities, as well as promotional things for the study, as well as promoting like legitimacy of the study. And part of my educational campaign, if you will, is really to discuss, why it's important to be part of a study like this and how it helps to advance science and how community health is connected to individual health. And so that, I think, really helped spur some interest into the study. And from that, our social network just really exploded. We started getting invited to do all kinds of talks, media, and recently I just did a guest lecture at Center College, and they were going to try to promote the study as well. So we're lots of opportunity for collaboration across the 4 counties in terms of where we're located. So within these 4 counties, we created 2 community advisory boards. And so really the point of this is to provide bi-directional feedback that really helps us to learn more about the local community and how people engage and what are going to be some of the priorities for the community. And so we've learned a lot and have really actually revised and changed some of our plans with community engagement based on some of our interactions. We have a lot of, from leaders in the city all the way to just community members of all ages that we've talked to that aren't even part of our CAB. And just to give you a snapshot, so within the 6 months leading to when we started recruitment in Boyle and Garrett, these are some of the things that my community engagement team and I were involved in. So as you can see, it goes anywhere from cultural events to faith-based things and media, and it's not just health-related events. We actually send to all of our stakeholders a quarterly newsletter to keep everyone updated. And so part of this, I never would have thought that I would have been involved in something like this, but we have a mobile exam unit. And so what this is bringing research to the counties where people come to this unit and actually participate is another unique design feature of the study. And so I collaborated with city officials for those that were being recruited from Perry and Breathitt County. We determined the best location was in Perry County Park, which is in Hazard, Kentucky, and about 20 minutes from the Perry-Breathitt County line. And so we were working with city officials, city engineers, and power and water. And what we had to end up doing was in both places, pouring concrete pads for the stability. And the city officials and the fiscal court, they really bought into this because we sold it as, helping to build their infrastructure, and the use of this can be multifaceted in terms of, bringing other mobile units to the areas, and specifically in Millennium Park, where we are now, which is Danville, Kentucky, in Boyle County. They have approval to build an amphitheater within the area so they picked the area that they wanted the concrete pad because they're going to be able to use it in the future. Okay, and you can go to the ruralstudy.org/community, and it kind of goes a little bit more detail into what we are doing as a research community, but also within our communities. And so I'm presenting in March at the UofL Community Engagement Monthly Seminar more about the specific methods for our core and our tracking methods and our impact and our reach. But one of the things that I really learned throughout this process is that we don't know what people don't know. And that includes their perceptions of their community health and of chronic disease. And so in September, I launched a community health and perceptions pilot survey where I'm asking people how they engage with their communities, how satisfied they are with opportunities to engage, and what their perceptions of heart disease and cancer are. Just as a quick snapshot, there's about 25 questions. So far we already have 100 participants, which is great. We're promoting them at the events that we go to. Okay, so what are we asking people to voluntarily do? A lot, but they are also getting a lot in return, and they're really buying into this idea of advancing science, but also thinking about how they can learn more about things that are going on in their body prior to when symptoms occur. And so for this baseline data collection, we ask people to come to our mobile exam unit. We have a mobile CT scanner. So we're looking at coronary artery calcium. It's a 256 slice CT scanner. So it's a large part of the abdomen area and chest area. And so unfortunately, fortunately for people, there's other things that can be found. So there's been incidental findings in Kentucky alone. There's been so far out of the nearly 1,100 exams, 13 where masses were found within the CT scan that no one knew about prior to this. And so this has been life-changing for a lot of people. For not just that reason, but for other reasons and the results that they get back. So we do spirometry and echo and ECG, blood pressure, looking at peripheral artery disease risk with ankle brachial index, anthropometric measures, and then collection of blood and urine. And so we have a biorepository. One of the cores is located at the University of Vermont, and they host repositories for several of the large cardiovascular epidemiology cohort studies for future analyses. And so we have a genomics core that's already starting to look within metabolomics and proteomics markers as we speak. And so we're asking people to do all this stuff and you know, provide a lot of their time. And so one of the big incentives of this study is that they get all of their results back. But before I have an actual report that I can show you in a second, but they do get a monetary incentive. That's not something that I talk about a lot within my promotion or my health education attempts. I find that not everyone is motivated by monetary incentives, but it is mentioned. So we have a whole process here where we have a mobile app. And if someone does not have a phone with access to apps, we can provide a phone to them with a 6-month cellular data plan so that they can ask our questions. And the big idea here between having the mobile app questions is because we're trying to reduce participant burden within the mobile exam unit. So while they do answer questions at a few different time points within the 6 months after baseline, they do just still answer questions on the MEU. And so this is an example of the return of results. And you know, we encourage people to take these to their practitioners. I've met with all the doctors and nurse practitioners and the main healthcare systems within these areas, so they know that we're there and that we're not, you know, trying to take patients, and this is not a clinical study. But these tests are read by clinicians. And so we just launched our rural participation portal where people can actually go on and look at their information. And so briefly, these are the types of questions that are asked across the surveys within the mobile exam unit. And so we ask questions regarding social determination, social determinants of health. So these include these facets right here. And then these are some of the other measures that we use, including lifestyle factors, as well as general health status, and just to name a few. So where are we now? We actually moved into Kentucky in December of 2024, having completed almost 4,000 exams across Alabama, Mississippi, and Louisiana. And so as we started seeing participants at the end of January of 2025, and saw 739 participants between January and September, and then moved to from Perry County Park to Millennium Park in Danville. And since the beginning of October, we have seen 355 participants from Boyle and Garrett. So we're on target right now to finish our baseline recruitment and be finished in Kentucky at the beginning of June. So what happens after our baseline visit? We are asking questions, like I said, at these various time points. And then we're asking people to wear a Fitbit to track their physical activity, their sleep, and heart rate variability. And then we have some ancillary studies that have already been funded. And so these ancillary studies are, you know, collecting additional information from study participants. And so they are asked within a few months of their baseline if they want to participate in these studies. And so then from there, we will do an annual follow-up telephone interview because we are interested in you know, how things are changing over time and how events may occur, after adjudicating events after their baseline. So we'll be continuing community engagement and really kind of phasing into this idea of not just community informed engagement and education, but also dissemination and implementation. So we'll be continuing our infrastructure of the cohort with adjudication of events. We've in the past 4 years, we've already had about 131 events so far. And I think I'm way over time here. I'm sorry. So let me just get through this real quick. Basically, I'm going to leave some links here. We have a policy. We already have our second wave where we're going to go back to these communities and do a second exam. And so we're already accepting ancillary studies. There's 16 that have been proposed, things that I'm interested in. As you all, some of you all that may know me, I've been around a while here at UofL. I'm homegrown and native to Kentucky. And I'm interested in cancer survivorship. And so how in the world did I get involved with this? And really that's pulling on my expertise in epidemiology methods and study design and community health and engagement is where my expertise was really valued within this group and this infrastructure. And so I'm working on an ancillary study to be able to evaluate cardio-oncology outcomes within the study. Okay. Sorry, I went over time here. I don't know if you want to have Jelani go ahead and do his talk before we do questions, or if people want to ask questions now.
I think let's move on to the next talk. And Ted, do you want to introduce?
I'm gonna let Jelani introduce himself. He's
Okay, that's the
I'll
best
never
way.
do it justice. He's fantastic.
Okay. Hi, everyone. How you doing? My name is Jelani Kerr. I'm an associate professor in health promotion and behavioral sciences. I'm also interim chair of this department. I'm happy to be speaking with you all today about a very interesting multidisciplinary or interdisciplinary project I'm working on with some people in the School of Medicine and the School of Social Work. We've combined strengths of our various methodological expertise, which are varied, to do this really interesting study focusing on HIV, alcohol, and the gut microbiome. So and Stephanie, don't worry about going over. I think, I don't think I'll take up a whole lot of time. But anyway, so here are the investigators on this slide. Everybody can see the present slide?
Yep.
Okay, all right, cool. Okay, so pre-exposure prophylaxis. What is this? This is pre-exposure prophylaxis, or PrEP. This is a highly effective biomedical HIV prevention approach. It was first approved by the Food and Drug Administration in 2012 in the United States. There are different formularies for it, but there are different modalities for it. But one of the most common modality is this daily pill that you can take. If you take it as prescribed, reduces risk of acquiring HIV by 99%. So this is something for people who are HIV negative. Right now, there's also injectable PrEP. Two types of injectable PrEP, where one can take kind of a bi-monthly shot, and then there's another injectable type of PrEP where you can take a shot once every 6 months. But the oral PrEP is still that's the one that is covered by most insurances. That's the one that has the greatest access. But there's also this gap in between the number of people who need PrEP and the number of people who are actually accessing it. So there are some findings that indicate that hazardous alcohol use may impact people's PrEP use. So there are some studies that indicate that that hazardous alcohol use may impact adherence to PrEP. Adherence is very important because that's what that's what helps ensure prevention. And alcohol's impact on PrEP-related behaviors may be exacerbated by issues of substance use and depression and mental health challenges. So, one thing to pay attention to. PrEP is not contraindicated with alcohol, although a lot of people think it is. A lot of people who are taking PrEP think that there may be drug interactions that may impact PrEP's effectiveness. Not true. So there has to be some education on that, and because of that, people may not be as adherent as they should be. So there needs to be more work in that area. Okay, so let's switch gears and talk a little bit about the gut microbiome. And I'll bring these things together in subsequent slides. So the health of the gut the gut microbiome is pretty important for a lot of things. It impacts our immune system, our digestive system. There's also mental health implications for having a healthy gut microbiome where you have a lot of varied bacteria in the gut. There are so we're seeing more and more people in science and in the media pay attention to the microbiome. PrEP may impact the microbiome, but that's been under researched. Alcohol impacts the gut microbiome. The combination of these may impact the gut microbiome, but this is poorly understood. And so we need more research to examine this. All of this may have implications for PrEP adherence, particularly when you start talking about side effects, and whether the interaction of all of these things are going to impact whether people are going to stay on PrEP or not. So, an intervention approach that's been used in public health and in social work is an approach called SBIRT. This is an acronym that stands for Screening, Brief Intervention, and Referral to Treatment. And this is an approach that's typically used in behavioral health, hold on for a second, especially for alcohol use and hazardous alcohol use and substance use. And it's a process for screening people for these conditions. In this study is alcohol. A brief intervention, which is this motivational interviewing based approach where you kind of talk with somebody, help them identify their goals, and really try to talk them through how to address barriers to getting them and achieving them. And it's kind of like a brief one-on-one counseling. And then referral for treatment for people who demonstrate the most concerning alcohol use. You can send people and refer them to treatment. So with our study, we combine all of these things. So we're doing clinic-based recruitment through UofL and Norton Healthcare systems to recruit people who are taking PrEP. We're assessing their alcohol use, sending a number of them through SBIRT, and determining differences in health outcomes. So this is a RCT. This is a randomized controlled trial to determine the efficacy of SBIRT. We're trying to examine two things. Does this impact alcohol use? Does this have impact on PrEP use and PrEP adherence? And all together, how do these things affect the gut microbiome? So these are our aims. This is a RCT, but it's also mixed methods. So we have qualitative approaches where we're doing interviews with people to try to see what's working and why is it working. We're doing the intervention using SBIRT to determine its effectiveness in reducing alcohol use. And we're also collecting we're also collecting more objective data to determine um, uh, how all of this may impact the gut microbiome, particularly if we reduce alcohol use. Um, how does that will that impact the will that turn into positive changes for the gut microbiome? So this is kind of a layout. This figure is kind of a layout for our study in our study design. We take a cohort of people who are engaged. We take people who are engaged in PrEP. We screen for alcohol use. For people who are, we use a measure called the audit, and which is a previously validated, well-used measure for capturing hazardous alcohol use. For people who are not demonstrating hazardous alcohol use, they have a brief meeting with um, our healthcare professional. We have a certified alcohol and drug counselor on our team. They say, hey, you're doing good. It's just, keep doing what you're doing. We keep going. But if somebody does demonstrate hazardous alcohol use, um, they have an interview. They're talking with our healthcare professional a little more, and they go to if they're demonstrating high risk use, they get the brief intervention. And people who demonstrate severe use get the brief intervention as well as referral to treatment. So let's see. Okay, so there's a lot going on with this graphic. I'm not going to go through all of it, but the most important thing to recognize here um, are the type of data that we're collecting. We collect fecal samples at baseline. People fill out questions around depression, anxiety, alcohol and drug use, and then they also do interviews. Um, and after, and we're collecting data at 3, 6, and 12 months. Um, and we're enrolling people for over a 12-month period. So to date, we have about 73 people enrolled in the study. 13 of them who demonstrate hazardous alcohol use have been randomized into either a treatment as usual program um, or the expert intervention. But we don't have a lot of the quantitative data uh, to really well represent with a level of validity to display in public. But we do have some qualitative, at least for these purposes. We just got some today. We just got some earlier this week that we'll process, and we'll talk more about. We'll go into more of that in the future. But we do have qualitative feedback from our participants about how this study has impacted them. So for example, Joe says, do I want to change anything with my PrEP use? Yes, I want to take PrEP more consistently. And these meetings have been one push to get me back on track with that. And that's the type of thing we're seeing from a number of our participants. Um, so in the okay, so I'll keep I'll keep going because we don't have a lot of time. But what we so some of our next steps, we're starting to put more emphasis on implementation science and translating our knowledge um, to address the gap between what our study finds and implementation within more clinical settings. So we don't want to just do the research and just publish and just leave it there. We want to and just leave it there. We do actively want to um, start implementing programming that'll have sustained impact over time. Right now, we've done a lot of it. This project focuses a lot on alcohol, but we do see the need to expand it to more work with substance use, especially as a lot of people are who we're interviewing also reporting some substance use. And we're also looking to explore the impact of these long-acting injectables and how those may affect the gut microbiome um, and their interactions with alcohol and substance use. So, okay, so it looks like we have 5 minutes left. Um, are there any comments or questions? I, and I think that can pertain to both of us, or if that's okay, Dr. Klein.
No, that's great. And for
Okay.
those of us who want to maybe go a little past the 1 o'clock hour, great presentation. Actually, all three of them are terrific. Definitely want to talk to Ted about scaling the system that he described. I think it's got applications in a lot of areas in the university. But let's go for questions for any of the three speakers. And if you got to go, you got to go. And if you can stay, let's stay a little longer. I'll start. I guess I'll try and prime the pump here. Stephanie, great presentation. I've always, not always, but for as long as I've known about it, the rural study is one that just really captures my imagination. I mean, come on, who among us who does translational research doesn't get excited about the words mobile CT scanner? You know, that's pretty awesome. Tell
Yeah.
tell us a little bit about what other universities you work with and how they work together on this project, because it's a big project.
Yes, it is. Yep. And we're about to embark on our second round of funding. This has been about 6 years. So within 16 institutions, we have a pretty large, infrastructure. We have a steering committee, an executive committee, and then we have a lot of subcommittees. And so I'm involved in several of these committees, actually probably all of them. But we have, a lot of moving parts, a lot of things that we're, checking all of the time, including we have a group that runs the sampling core that works with myself and the data collection core at UAB. And there's a lot of synergy between all of these institutions. And so, everyone's expertise across these areas have really, I guess, helped elevate us. But there's constant collaboration and constant, bringing in new people and trying to focus on early stage investigators. And one of the things I don't know if I did a really good job of is talking to people about just the opportunities that there are to collaborate within this study. I mean, I'm being approached by a lot of other institutions to do ancillary studies, and I'm like, I want to talk to people at UofL about how they can leverage this data. They can do manuscript proposals, abstracts, and I'm part of the ancillary studies subcommittee and the publication and policy subcommittee, and can walk people through that process. There's a whole lot of people here at the university that do environmental health, and we're not collecting individual level environmental health data at this point. And so I did talk to Ted too, just to give you another example. Our mHealth core is through UMass, and we are actually discussing inviting them here for a grand rounds to discuss all of the things they're doing with cardiovascular cohorts and how they're leveraging a lot of their work, not just for looking at etiologic questions and epidemiologic research, but also like the translational and clinical aspect of their work as well. So hopefully that answers some of your questions. We have like our imaging core is out of Duke, and he reads all of our echo cardiograms, a cardiologist from Duke. And he's an epidemiologist. And then we have a pulmonologist who's actually the PI of the Framingham Heart Study, who reads the CT scans. And so, we have a lot of different people that are, great. And now, would I recommend trying to do a UO1 in this level of complexity? I'm not sure if I would want to embark on the lead of that. But I do think there's a lot of value in this team science, and it takes a lot. I mean, we prepped for this grant before the proposal. This pie in the sky idea was with 10 states. And when the RFP came out, the budgetary restrictions had us dwindling it down to 4.
So I'll just follow that up with, to paraphrase Robert Browning, an investigator's reach should exceed their grasp, or what is a heaven for? So UO1's, our office is here to help people who want to submit and draw together UO1s. Lee Botner, who's on the call, leads the research development group. And I think people who have written large multi-investigator, multi-center grants can tell you that they are just fantastic.
Mhm.
So don't say never.
I
Don't
don't
say
know.
I
I
don't want to
agree.
do
I
it.
mean, I'm definitely thinking about, writing my own here for in Kentucky. So if, people are interested in, talking about, collaboration just for the Kentucky population, I'm definitely interested in that. But as you probably know, like with these larger studies, it's a strategic investment. And so then they go from a grant mechanism to a contract, and it's, aligns a little bit more with the institution and not necessarily all the investigators as it moves forward.
Any questions from the rest of the group? Okay, well then I'm going to throw one more out for Jelani, and then I'm going to go try and find some lunch myself. Jelani, there are, and I may have missed this because I had to step away, but there are groups here at the university who are showing a connection between manipulation of the microbiome and alcohol cravings. And I didn't know if you had had any conversations with them, as part of the work that you're doing.
We I haven't. No, but I do know that there's good. I know there's good research and good work going on. Um, looking looking at GLP-1s, looking at probiotics, how these things may play into health and overall in the gut microbiome. Excuse me, overall health in the gut microbiome. So that is an area that we want to expand
You,
into
you,
and for future applications.
you may want to sit with Ted and reach out to Dr. McLean's group, who actually have an agent that they've demonstrated decreases alcohol cravings by changing the microbiome. At least that's my very primitive understanding of what they've done. And it may be something that you can incorporate into your next study.
All right, thank you.
Sure. Okay. Everybody's ready to go, like, clear the bread shelves, you can tell. Well, if nobody else has any other questions, then I guess we'll call it a day. Everybody stay safe and warm over the next week. And if you need any help from the Office of Research and Innovation, please reach out. And we definitely have some resources that can help with your research, whether it's a small grant or a large grant. But thanks a lot. Everybody have a good day.
Thank you. Bye, everyone.
Bye.